Welcome to Trojan Talks. This podcast is a space for conversation with leaders both within and outside of USC to discuss the ideas shaping USC's future. My name is Byung Kim, Interim President of USC, and I am absolutely delighted to have as a guest today Dr. Indy Gill, the chair of our Department of Urology at the Keck School of Medicine and one of the most renowned physician scientists in the world, famous for his innovation in robotic surgery and for his global leadership. Indy, it is such a pleasure to have you here to talk about what you've been up to.
Thank you so much, President Kim. A longtime admirer of yours, and thank you for this very kind invitation. I'm honored.
I wanted to start on a personal level. I wanted to ask you, as someone who grew up in India and moved to the United States for some of your training, how you first came up with the idea of becoming a physician and what you were interested in as you were growing up in India.
Sure. Small town in India, Ludhiana. As regards medicine, our immediate and extended family, literally everybody is a physician.
Okay.
22 plus physicians all over the place. So it's kind of boring. And so that's all I did was grew up with medicine all around me.
So if you hadn't become a doctor, you would have been the black sheep in the family.
Yes, I was actually wanting to become a national cricket player. Cricket is what fired me up. But yes, and so did my initial training in India and then came to the US, which was an aspiration. First came to the Cleveland Clinic and spent the initial 12 years there, and then USC now for the past 15.
How did you decide on your specialty?
Urology, honestly, India was the hardest to get into. So for 2 spots in the program where I did my training, there were 500 applicants, each of whom had done their master's in surgery. So just because it was difficult, it just kind of attracted me to it. And once one had done one's training there, then all that became routine and mundane. And I'm like, what's next? And so the US beckoned, and elevating one's surgical expertise, elevating one's understanding of the field was what drew me here.
Wonderful. And this attraction you have to the difficult or the impossible is something I think we'll hear more about later in this conversation.
Yeah, I mean, I'm sure you're no different. For me, when I start getting comfortable, I start getting uncomfortable. I start feeling I am not progressing. And my preferred state of existence is one of simmering discontentment, simmering restlessness, such that I feel it is such a privilege to be alive, to have all these amazing opportunities around us. And if one is not striving constantly to avail of them and to improve, not just myself, but the field, I feel it's wasted time.
You came to the Cleveland Clinic from India, and you trained there, and then you were later on the faculty, of course, in the Department of Urology there. Right. And you had a very successful career, and you could have, I'm sure, continued at the Cleveland Clinic had you wanted to. What drew you to USC?
I went from being a fellow at Cleveland Clinic to chair of the department in 10 years, which is the number 2 program in the country. So I was beyond delighted. Again, things were becoming routine. We had built, what I believe at least, is the premier laparoscopic surgery team in the world, and developed the field, as a matter of fact. And then switching over to robotics was pushing this. And that became kind of standard. Then I felt that, if indeed my team and I, we feel we are the best in the world, let's take our show to a more challenging environment, like the one in Los Angeles, and specifically USC, because USC has long been the leader, if not the leader, in big open cancer surgery. And I felt that if we could bring robotics to that same level of big cancer surgeries, it would be, and I got the job, it would be a compliment not just to me, but to the field which we are trying to build.
And you've innovated in robotic surgery, which we'll discuss later, but you also have all of these other expertise that you've developed in transplant surgeries, kidney disease, all sorts of other areas that have somehow come together in an amazing way. Most recently, when you and someone who trained with you at UCLA completed the first successful inhuman bladder transplant.
Correct.
And that was, I think, in May.
Correct.
And it justifiably made global news around the world, the first of its kind ever. Tell me a little bit about how this idea came to be.
On the back of a paper napkin in the cafeteria at Keck Hospital during lunch break. And we are like, we should explore this. We have thousands, if not more, of patients with terminal end-stage bladders. And life is just not palatable. You don't know what you have until you don't have it. So we take bladder function for granted. I mean, of course, but there are many, many, thousands upon thousands of patients for whom this would be a dream come true. This patient that we had done surgery on had not passed urine from his normal way for 7 years. And so how this came about was we first innovated the concept. We then did the basic preclinical work in the lab at USC and confirmed to ourselves that this is even technically doable. And once it's doable, is it going to be durable and persist? And we confirmed all this in the preclinical arena before venturing into the first in human.
How many years did it take from the conception of the idea to the actual successful surgery in May?
I'd say about 3 to 4 years.
How many surgeons and others were in the room doing this procedure with you?
We did all the preclinical work at USC, developed all the techniques, and then we did the first clinical case with my colleague, Dr. Nima Nasiri at UCLA. There were, I would imagine, about 10, 15 folks. It was a Sunday. And it was exciting. And when we took off the clamps and everything lit up beautifully, people broke out into spontaneous applause, understandably, and felt that it was, quote unquote, a little historic.
This particular operation took so much planning, so much work, so much coordination, and it's wonderful that we were able to do it with UCLA. Are you optimistic about the ability to actually scale this and actually make this available to more people and not just consider this a research breakthrough, but an actual procedure that other patients can benefit from?
I really believe so. Because the patient pool of folks with terminal diseased, non-functional bladders is huge. So I think what we, and the fact that this patient is dry, continent, and able to empty spontaneously are two huge things. Okay. This now gives us the basis. Next step would be to reconfirm these findings in another 20 to 30 patients and be able to demonstrate that this is the way we can expect this going forward. And it would not be the end of the world if somebody had to catheterize themselves intermittently to empty. That would be totally fine as well, because that is the current state of the art when we take someone's bladder. So initially, Beyond, it would be for folks with benign terminal bladders, no cancer. And as we make this happen, that field is the number of patients, folks having neurogenic bladders, meaning spinal injuries, and thereby terminal bladders. Folks having interstitial cystitis, which is an inflammatory condition that really contracts the bladder down to a walnut, makes life terrible. Ketamine cystitis, folks are, the drug abuser. So we feel conservatively a few thousand patients could have benefit from this on an annual basis. Of course, I'm projecting, but I really feel we can do this. We can build this right here, the world's best and first bladder transplant program.
Wonderful. Indy, before this first ever human bladder transplant, you are, of course, known across the world for being one of the global leaders in robotic surgery and one of the true pioneers in the use of this technique. And I wanted to talk to you a little bit about what is the next frontier in robotic surgery. One of the things that we've talked about in the past is this emerging technology that might allow us to do robotic surgeries from across the world.
Correct.
And I was wondering if you could share a little bit about what the future might look like for robotic surgery.
Sure. So what you just alluded to, doing distance surgery would be telepresence surgery, wherein the patient is geographically in a different room, in a different place in the same city, a different city across the world, etc., etc. That, in my mind, is more a victory of telecommunications rather than any real innovation on our part. As long as the feedback loop, from the time I execute a movement till the time it is, I do a movement till the time it's executed at the distant site, and that image is relayed back to me, as long as that circuit is under 300 milliseconds, it is near real time. So I will feel literally no different as if I'm operating here versus somewhere else. Fundamentally, that is a victory for telecommunications. And so I think a bigger impact would be enhancing robotic surgery, which is currently the expert will be able to get to journey's end expeditiously without any injuries, any complications, and do an excellent job. The novice or the intermediate level surgeon will take his or her time to get to journey's end. And in that meandering are the setup for injuries, complications, increased blood loss, blah, blah, blah. I feel that with AI, we are building currently what we think is going to be the world's biggest annotated video repository, where all the thousands of patients that we do would be annotated and be then fed into a AI and ML engine that would then be able to take each annotation and be able to, within the confined space of XYZ coordinates, be able to put in fly and no fly zones, guardrails. That would actually enable novice and intermediate surgeons to get even more adept quicker. The complications, etc., would go down. So that is something that I'm fired up about. Building the world's best repository is something we are fired up about. And then taking these two things in the coming years and then take it to automated surgery, wherein, yes, we will do some part of it, but a reasonable aspect of it would be fully automated. And automated surgery is a whole order of magnitude more difficult than automated driving. Because in the driving, yes, somebody could jump in front, but he's hoping we have a couple seconds to react. In surgery, everything is changing every second. And an error, a millimeter error could be catastrophic. And so since with respiration, everything is moving. And then as you keep doing surgery, you are moving the organs around. That's the whole point. We are able to, if we can automate some of this stuff, that could be a beautiful thing to look forward to in the future.
That's amazing. How far in the future do you think that is, where portions of an operation in perhaps more routine cases could be done robotically?
I would imagine in the next 2 to 3 years. And here's hoping. It's happening right here at USC. We are working on it. And we'll have to make a recruitment or so to make that happen. But that's something we are looking forward to in a big way.
And of course, AI is already changing other parts of the practice of medicine, from note-taking to call centers and really, hopefully, allowing physicians and surgeons like yourself to be really spending their time on the things that they really need to be spending time on, as opposed to things that a robot or a computer can do.
Very well said. The goal here is, in my view at least, AI in healthcare would be I like to think of it in two levels. Level one, the daily, the low level mundane work. And the level two is the truly transformative work. The daily low level mundane work would be call centers, would be automated reading of pathology slides, automated reading of CAT scans, MRIs, ambient scribing, etc., etc. And I don't mean to say these in with any or of a negativity, because everything we just talked about is huge. These will allow us to elevate ourselves to the top of our license, and in doing so, we would have moved the entire field of medicine forward. One of the things, as you know, we've been working on is to automate the clinic notes. Currently, 1 billion patients have outpatient consultations every year in the country. To construct a note takes 10, 15, 20 minutes. I mean, that's a lot. And it's the same thing over and over and over. And we can and have already automated this. If we can cut out 7 to 10 minutes per consultation, you can imagine the downstream effects could be dramatic. So that would be, I would still put that in the category of the lower level optimization of daily workflows. The higher level would be where we are now bringing AI's incredible power into drug discovery, into foundational genomics, into predictive analytics about how individual patients would do based on the data that are available for that patient, et cetera, et cetera. And that, I think, will be a little bit further down the road. But at the pace at which AI is going, I mean, to me, it is just mind-boggling.
You sound very optimistic. And one thing that we haven't discussed specifically is the challenge of physician burnout.
Correct.
And part of, I think, what, as you know, physicians hate the most is the administrative tasks that aren't really allowing them to operate at the top of their license, as you put it. And it sounds like you believe that AI is already starting to make a difference and will continue to make a difference in terms of minimizing and streamlining that administrative work.
Absolutely. We didn't go to med school to type. Right? And it's just you're absolutely right. Burnout, 50 to 70% of all US physicians, just think about that for a second, burnt out. Because this is not nourishing work. We want to take care of patients. We don't want to take care of stuff to then take care of patients. Stuff should be automatically taken care of for us. Why do I have to walk into a clinic room and the patient is driven or flown in, and we are sitting there and I'm asking, sir, please tell me, why are you here? What happened? What is the problem? What a colossal waste of time for everybody involved. My expectation now is I walk into the clinic room, the patient's entire detailed history should be available to me automatically without anybody's work, any human's involvement in it. And we have already done that. Now the point is to scale it and take it to the next level. That right there could be a huge improvement. And it also allows us to standardize, right? Otherwise, it is dependent on, you are an excellent physician, I'm not. Your conversation with the patient is going to be enlightened, mine is not.
Or how much sleep did you get last night?
Exactly. But with this, since it's all technology run, the engines that we are building are physician invisible, physician agnostic, physician independent. And we will give you the detailed clinical story of the patient. Now you take it from there as the physician and start engaging with treatment planning and really addressing the patient's concerns, fears, and build bridges with them.
Indy, you came to USC because of the impact you believe that you could have here. And to have that impact, we all know that it takes a village. I'd love to have you talk a little bit about leadership and how you not only lead the way in terms of your own clinical and surgical innovations and work, but also how you create a culture within the Department of Urology and within the Keck School of Medicine that empowers and encourages other people to take risks in order to deliver the very best patient outcomes that we can possibly deliver.
You are the epitome of leadership, sir. And it's a privilege to be interacting with you. And thank you for this again. As regards, at least in the Department of Urology, I feel that my job is to first and foremost take care of the people who are taking care of patients. So my job is to build an extended family atmosphere, to be very supportive of everybody. As long as people are aligned in the overall department's mission, my job is to try to the extent I can to bring a smile to the person's face. I can't do everything. We can't do everything, of course. But we engage in constant brainstorming. It's not whose idea it is, but what is the idea? That is what we go after. I want to do everything I can to give them the tools, minimize red tape, roadblocks, etc., and give them the things that they need to be able to do clinical work plus the innovation. So having a disciplined focus, like despite all the daily work, we have to still keep moving this thing forward, is important. And then to provide the necessary facilities. So we have been very fortunate recently to receive truly a momentous gift, a $55 million philanthropic gift from an anonymous donor. And I could not be more grateful. I could not be more grateful for it. This will change the trajectory of not just our department, but truly the fields in which we are engaged and interested in. We have already put together a list of projects, and 3 or 4 of them are the big ones. And I look forward to putting together with the teams, the work effort to deliver this within 2 years.
And a lot of the impact that this gift will enable, Indy, are some of the things we've already talked about, right?
Correct.
In terms of innovation, in terms of clinical excellence, and in terms of really incorporating AI into the work in order to advance it.
Correct. The projects that I'm alluding to are things we have already thought of and envisioned over the past 3-4 years. The lack of funding is what has been the stumbling block. Now that is gone. This is truly exciting times.
I wanted to ask if you had any thoughts for students who are entering medical school, thinking about medicine, anything that you wanted to share with them in terms of the way that their careers and professions may be different from the ones that you've had,
right,
but still very exciting.
Right. I mean, I would just say to the next generation, the students, is that you are at USC. Therefore, by definition, you are world best. Okay? And take that seriously. This is a major opportunity. You are living in the age of artificial intelligence. This is literally mind-boggling, the era in which we are living at. And I can just tell you from my personal perspective, never before have I been in an environment where things are advancing literally every 2 weeks. That is a stunning pace. I feel that for the students, the point I'd like to make is there are 2 ways I feel that you can innovate in today's age. One is to do fundamental scientific discovery. And the second is to do innovative application of established technological concepts and things.
Indy, one of the things I admire the most about you is that at the same time that you are really trying to push the frontier of innovation and discovery, you're also all about giving back, not just in the United States, but also across the globe, including in your native country of India. And I just wanted to ask you to share a little bit about some of the ways that it's been meaningful for you to have been able to kind of give back and spread some of the discoveries and innovations that you've developed across the world.
Sure. one has been privileged to be interacting with literally the entire field of urology and robotic surgery. We have gone literally all across the world to educate, teach, do live surgery demonstrations, etc., and invite those surgeons into our operating rooms to, again, continue to discuss and brainstorm and move things forward. Specifically in India, we have been interacting with 2 or 3 of the top hospitals there, and the Indian surgeons are very skilled, and for them to be able to see in real life, as opposed to a video, as opposed to conversation in the operating room, real live stuff, which is not always easiest to do, but we do that effortlessly now. Our team is so used to operating live in front of an audience. I've had the enormous privilege to train and work with about 140 postgraduate fellows, even larger number of residents. But as regards the larger field, beyond honestly, I feel very, very good. I feel very, very good about how our team, the USC Urology, Robotic, Oncology, Cancer Surgery team, how it is perceived worldwide is just an enormous sense of pride, joy, fulfillment, and humility. It's been, so far, it's been lovely. And we are just getting warmed up, honestly.
Dr. Indy Gill, thank you very much. Thank you for your leadership, and thank you for your impact at USC.
Thank you very much, President Byung.